Welcome everyone to this Scotland-Malawi Partnership COVID-19 conversation. This is our 6th meeting in which we seek to pool our knowledge and build up a picture together of the lived experience of COVID-19 wherever we are in Scotland or Malawi. We're fortunate to be joined today by senior figures from both nations, the Deputy High Commissioner, the Honorary Consul in Scotland, co-chair of the Presidential Taskforce on COVID-19 in Malawi, all protocol observed, and everyone's participation is greatly valued. We're grateful that experts will help illuminate the COVID-19 situation, but these calls are about assembling a jigsaw, and each of us holds a piece required to get the full picture. So please do volunteer brief comments and questions using the chat function for the Q&A and discussion sessions. My name's Stuart, I'm on the staff team of the Scotland-Malawi Partnership, and I'll be facilitating today's conversation. However, it's very much shaped by SNP members and their partners, the Malawi-Scotland Partnership, participants from previous meetings, and the leadership of David Hope-Jones and the involvement of my colleagues. Craig is hosting the technical aspects of the Zoom call today and has muted all of us just in the interests of audibility. When you're invited to speak, please do unmute yourself by clicking on the microphone image such that the red diagonal strike through disappears. Equally, just for the stability of the connection, we encourage everybody please to keep videos switched off unless speaking. Gemma Conley-Smith leads on communications for us and social media. Please feel welcome to tweet at any point or post about today's meeting using the handle shown on the slide, which is @Scotland-Malawi. David will give a summary at the end of the first hour and identify key actions arising at the end of our time together, which is scheduled for 90 minutes today. The full recording will be made available online after the meeting via our website. We'll begin in session 1 with Malawi updates, hearing about the political context and any factors impacting COVID-19. And then from the Presidential Taskforce and the College of Medicine. There'll be then time for Q&A and discussion, with some participants having submitted questions, as everybody was invited to at the point of registration, but equally all questions are welcome that you bring today, and our only limitation is time. In session 2, we'll have updates and discussion on, amongst other topics, testing, public messaging, and PPE production and distribution, and hear updates on appeals. With time in mind, let us begin. MaSP and the SNP are both politically neutral organisations. MaSP's CEO, Vera Kamtukule, took leave to work in her own time in a politically neutral position as the coordinator of a non-partisan professional observers group in last Tuesday's presidential election. Vera, may I invite you please to share with us your reflections on the political context for COVID-19 in Malawi now.
Thank you so much, Stuart. Can you hear me?
Yes, thank you.
Yeah, but unfortunately you cannot see me. I hope you can hear me. We went to the polls on the 23rd of June, and we had about 115 observers spread across the country for our team. Our task was to observe everything that was happening from the time the polling centers were opened to the time that the result sheets were transferred to the district tally center. Because what happened was that the tallying happened at the polling stations, and then the results were transferred to the district tally center upon signing by the party monitors and other officials at the polling station. But I think I had already said this in the previous meeting, where a lot of COVID-19 prevention measures were compromised during the campaign period. And we observed that even during the election period itself, we didn't have social distancing. Even though the MIC had ensured that we had hand washing baskets, basins, soap and everything, a lot of people were not doing that, and there was no one who was really enforcing people to wash their hands or to observe social distancing. And then I think at the district tally center, it was the same. I think I was in Lilongwe district tally center. It was packed, severely packed. There was no observation of social distancing there. And I think for now, it comes as no surprise that we have an increase of infections at the moment, standing at 1,224 as of this morning, with 260 recoveries and then 14 deaths as of now. But I think what is made apparent at the moment is that I think for now that people now are settled after the elections have been done and dusted. People are now seeing that the COVID-19 pandemic is actually very real, because of late we have had senior officials, government officials being infected or testing positive. Just today we've heard that one of the doctors up north, I think he's a district health officer, has tested positive to the virus as of yesterday. So when you hear things like those happening to people that you know, senior government officials, people that have everything at their disposal being testing positive, it has, I think, come as a shock to the nation at the moment. So while previously, like a couple of months back, 2 months ago, people had opposed to the lockdown, now it seems to be the sure way of doing things, because we have now, in almost 3/4 of our districts out of the 28, we have cases in almost each and every district at the moment. And so because we are not testing that much as well, we should be beyond the 1,224 that I've talked about, but it's because we are not testing as we should. Maybe this number may not be a true reflection of what is happening on the ground. So I think in a nutshell, I can give that brief for now.
Vera, thanks very much. Worrying to hear the situation of the increase of instance of cases. Important as a development, it would seem, if people are starting to take further measures and give credence to the existence of the virus in Malawi. I wonder if we might then move, please, to the co-chair of the Presidential Taskforce, the Dean of the University, Dr. John Phuka. Dr. Phuka, you're very welcome. Dr. Phuka, I wonder if you're hearing us okay, and if you're unmuted. Perhaps then, Professor Mipando, are you with us at this stage from the College of Medicine, the Principal of the College of Medicine, Professor Mwapatsa Mipando? Not quite connected yet. Okay. Well, I wonder then if I might give a brief update on the situation in Scotland and England as we find it, and give an opportunity for our Malawian colleagues to join us. We understand how incredibly busy everybody is at the moment, and the great calls on their time. And of course, our first principle is to do no harm. We don't want people.
Sorry, it looks like problems, but I can hear you well.
Okay, Dr. Phuka, very, very good to see you. Thank you for being with us. Can you hear us okay?
Yes. I think I just had technical glitch on the microphone, but so I can go and present.
Yes, please. That would be great.
Okay, so let me share. I think I'm able to share right now.
You should be able to screen share, I think.
Yes. Are you able to see?
I'm not, in fact, seeing your screen. Are others, I wonder?
Can't see it either.
Oh, there we are. Maybe? No, that's somebody else. Screen sharing is turned on, I'm assured, but we're not seeing you just yet.
Am I able to share now?
Yes, it's just coming on just now. Thank you.
Okay. Yeah, so I wanted to share a few slides and maybe some insights based on the giving the update. So when you're in Malawi, this is what we are sharing on a daily basis. This comes from the FIM, and I think one major role I've played is to ensure this is happening on a daily basis. So what it shows is the total number of confirmed cases, that's cumulative. On a daily basis, we present the new cases, take away the recoveries, and we have the active cases. There, although we have 260 recovered cases, I think we might have actually a bit more because we're somewhat overwhelmed in the system. The discharge is suffering from that. So that number could be as well as maybe 100 more or so. What's also critical is for us to show the level, the output in the context of testing. So we're at 14,000 tests done thus far, and sadly we've lost 16 of those that have been affected. Then I plan to show you the EpiCurve. So this shows from the first case that we had on 2nd April until as of yesterday. And I think you can clearly see that for the first 2 months, it was largely flat.
No, you handwritten. No, he just got it. He was everywhere, but now he clicked it away again.
Yeah, I'm sure. So largely the first 2 months, we had very few cases, then we have a jump, I'll explain that, then we had sort of a slow rise, then in 2 weeks later, after the first jump, we see another jump. So try to explain that will be the next slide. So this sort of explains all new cases as we see them, and in the first 2 months, we have the first 100 cases. That almost triples within 5 days or 6 days by the injection of 200 more into the pool, largely because of returning Malawians returning from South Africa. Then we had sort of it's propagating slowly, accumulating slowly with a few more other new cases. So we have a rise until the 18th, which is 2 weeks later pretty much. And then we see that in that 2 weeks, we have 300 more. Now, when you look at that, you begin to sense that, oh, okay, the first 100 doubled to 200 and somewhere in between 150, but that doubles in the next 2 weeks to 300. And then that again, in the next 10 days, doubles to by additional new cases, 600. So we are where we are with the the 1,200 cases, a little bit more, but on average you can consider still that. So I've tried to sort of on the left make some notes on the doubling. The point here, I'm trying to look at the doubling speed so that I can simplify the concept of exponential curve. When you use figures, it's easier. But the major factors are, as put on at the bottom, are returnees from South Africa and imported cases, which are more or less similar in number now. So in the first phase, it was mainly imported cases. Then, crowd control and imported cases, but crowd control seemed to be over and above whatever that was happening. Then clearly we have an impact by the returnees. In between, imported cases are increasing, but now the 600, that's where we see almost equal numbers of the imported cases, local cases 581, and imported cases round about 600 in each of those categories. So we initially, it's strategies we're using perhaps are in play. These include closure of school, reduced attendance to churches, social activities, but we've also seen enhanced activities in hand washing. It may not be necessarily the same throughout, but we saw some in early phases some element of that. Then at least we are learning, and we have adopted not handshaking, although we do some able contacts and trying to work our way around that. So those are some of the measures that have really worked, and perhaps also some of the strategies to support the actual measures, like making sure that we have enhanced hand hygiene, as well as reduced physical contact and social distance. So some of those were too close, but other elements haven't worked in our favor, and these include large crowding. I think the previous presenters talked about that. Social functions, funeral, weddings, some of the markets, use of face mask. We have not quite adopted that. Where we have tried to do it, sometimes we don't do it so well. And hand hygiene in institutions and workplaces seems to be largely at the point of entry, but once we go inside, it seems to be business as usual, and yet we can spend a lot of time inside there. This again is affecting the healthcare system, where we have some cases. We are trying to categorize who these are specifically, but others in research sector, others in offices, but also frontline workers are affected. When you take the whole number of 16 out of 1,265, case fatality rate is 1.6, which is really low like everywhere else. But our case worry comes from the admissions, where the case fatality rate is 43%. 16 out of 37 of those that died are from 37 admissions or less than 50. You can extrapolate that in assuming that we don't have, we have some that are not coming to the hospital. Give me another 13, I would say 16 out of 50, but the 16 may also go up. So it may still hang around the same 43%. Now, some of the elements that one could say going forward we really want to move is to sort of get to the population to come to right appropriate level of perception of danger, right perception, context of susceptibility, two extremities of severity, others are symptomatic, nothing, no symptom at all. On the other end, severe cases where within the 3 days, what we're noticing is that those that have suffered a great deal and those that actually we have lost, oftentimes within a night, they have gone to all these sort of facilities. They have tried to go doctor shopping to that facility. They don't feel well. They come to another, maybe private sector. Then they come to the central hospital. We take samples. By the time sometimes we have the results there, we have lost them already. So we seem to have really two extreme ends in this, and even the risk communication needs to talk towards that, because there's a feeling we don't have the disease, because those that have, the majority of those that have a condition are asymptomatic. Therefore, the story is there's no COVID or it's not serious. Then the benefit of good behavior needs to be sort of shared very well. But I would also want to coin in what I'm calling reflective walking hazards. The feeling of that perception of yourself, considering yourself as a hazard, and at the same time, whosoever you see across the street walking closer to you, imagine that this person is a walking hazard, is asymptomatic, and really is bringing danger to you, or you are taking danger to the next person closer to you. Some of the challenges, of course, reflecting on that is low perception of risk. It can be considered in several aspects. Raw self-efficacy as well is one element where people feel they can't really do some of this. They can't buy the face mask. At institutional level, we can't set up things to support. So this low self-efficacy is both at personal and institutional level, and we need mechanisms like motivation. Some of the solutions, these can be motivated from all others, but I'm thinking interpersonal communication at high level, motivation, mentorship, and others. Person-centered approach could be one of the most important elements. And low reflective empathy needs really special messaging, because for people to come to that level of considering themselves a hazard, yet they have nothing, it's another higher level of perception. So that needs special attention. Then in terms of infection prevention control, which is a major thing, I think we need at this point not to meddle people with so much information, but bring really 2 or 3 messages across. So one may be to interrupt a transmission. One has to self-protect if you have the capacity, at least all the adults, and maybe they themselves helping children and so forth. And I think that we may see children as a risk, but if they were well taught with one message, always have your hands clean, find ways of motivating them, find ways of making it interesting, they could be our real major way of interrupting this. So self-protection to adults, but also limiting spreading, meaning that if you imagine yourself you have, then you protect others by limiting the spread, and then limiting hospital-based infections, which could be slightly totally different angle of infection prevention. But the first 2 to me are key, and those you do by cleanliness of the hands. I can tell you, not touching the hand the face is very, very difficult. But if we focus on one, then the not touching the hands comes later. But if we ask them to do 2 things, they are getting this. I believe people are getting disappointed, because oftentimes they find themselves touching the hands. Therefore, that may bring in mixed messages. So I would really wish we focus on just one message: clean hands. Even if we know that over that, then you also have not to touch the face. But get one up, really up, and then try to integrate the other. The other is the self-protection, as clearly indicated. Then we shield those that can't self-protect themselves, adults and the elderly. So some of the transmission that we see, challenges we see is the increased local transmission in general, but community transmission is where we are. We have several clusters. We have in every district except 1 or 2, pretty much. Inland, 1 district, but and Likoma, which can be considered a district by activities or implementation, as another. But all other districts have cases. So really, we are at community transmission, and this now we need to be saying this, because that's where you also say everyone is likely to be a carrier. Everyone you see is a walking hazard. Institutional and workplace transmission, we have seen this by some data that's coming from some of the banks, some of the government institutions, including, which I can mention without any concerns of branding issues, is our own response center, where the Public Health Institute is housed, at where we had about 50 cases. So huge challenge when the war comes into your own camp. We have had this in one of also the public offices, the DC, one of the Chitipa, the whole the DC's office, District Commissioner's office affected. So healthcare can have its own maybe special solutions, triage, PPE, and then again, compliance control. One can call it quality control, but I would want to be very specific: compliance control. Behavior support is one solution. Mandatory use of face masks should really where we should be going, notwithstanding the fact that some are complaining of quality issues, allergies, and so forth. And then mandatory hand sanitization, more especially in workplaces, at multiple levels, not only at the point of entry. I think we need to do that to begin to see if we can interrupt some of these. Testing, we need to sort of, it's a challenge. We had wanted to do 7,000 tests by the end of June. We just doubled that to 14,000 by the end of June. However, we would want to be testing about 2,000, but I think constantly we also want to flex our muscle and relax in some of the activities. Really, if we're going to go that way, not as the previous presenter to say, well, we lock down, then we need to double even the testing. And that is a diagnostic case because there will be more cases and we need to double our impact. Screening, I've left it as a hashtag, as just a number that should be really large so that we can also know what is happening because we don't have a clear community status at present. Although we can be assured that the proportion of, say, 50 cases, serious cases, and about 1,000 is in the same ratio of 5% to 80%, and a total of about 1,000 from 56 severe cases. If you consider severe cases as 50, and then the 1,000 thereabout could be the same proportions others I've seen elsewhere, over 5% severe, moderate 15%, and severe, asymptomatic at 80%. So 50, 150, 800, as to about 1,000, plus minus standard deviation confidence intervals. The 1,200 would be within range considerably. So what do we want to do in testing? We need to sort of increase screening clearly, but we also want to increase institutional based screening. And this is really, really important because we see clusters that are based at workplace, institutions that are academic in nature, schools, private schools, and wherever. I think we need to think of that. We need to decentralize the testing. However, we can do it by other new innovations because we are largely dependent on molecular, but we need to think of other things like antigen tests and so forth. Then surveillance amongst healthcare workers. We need to think of digital surveillance, which we can do in institutionalized places, part of the motivation as well. And then we need to think out of the box, move out of the orthodox approaches of mostly PCR, validation of other issues. Then we need to strengthen our supply chain because as we speak, we run out of sample collection bottles and swabs. WHO had to come to our rescue in an emergency manner, which we can do better in that. So pre-planning and so forth was a challenge, but I think we are thinking of having a dashboard with warning signs to support that mechanism. Some of the mathematics I just talked about, we are targeted, if you look at the sort of third bullet, major bullet, 700 by end of June, we have actually done twice as much. Medium to long term, we want to do 500 to 1,000 tests by July, but I think we need to really think of that, maybe build up to 2,000. I really think we need to move that to 5,000. To be able to do that, our capacity of PCR and gene expert on the test is exhausted, less than 2,000, just around 2,000. It means we need both equipment, new equipment for diagnostic of molecular levels. But we are also very hopeful that there could be other elements. That was just some explanation elsewhere, so I'll skip that slide. Then I'll come to the issues of behavior change as I wind up the research aspects, care practices at community level, clinical care in the hospital. We need to have our own standards that can speak to our activities. So those will be some of the research areas. There could be more, and clear there are more, including participation in the solidarity trial by WHO. Thank you very much for listening. Thank you.
Dr. Phuka, thanks very much indeed for that very comprehensive update from the joint task, from the task force there. In discussion with Professor Mipando, he was very keen that you had the 5 minutes allotted to him there, with us having lost a couple of minutes at the beginning, and Professor Mipando standing by to join you in taking questions, Dr. Phuka. So I wonder, Dr. Wilson Mandala from the Malawi University of Science and Technology, you expressed interest in asking a question at registration. Do you have a question? Okay, in that case, I'll throw it open. Who would like to follow up with questions for Dr. Phuka and Professor Mipando?
Maybe John can ask. Wilson wanted to hear about the numbers by August. What are the possible numbers? I think that's a question from Mandala.
Thank you.
Interesting question. Difficult to predict, but as you see, the doubling itself is reducing. So one would expect that if we double in the next 10 days, the past 10 days, maybe in a week we had 2,000 thereabout. In 3 weeks, assuming we continue at the steady state of doubling, then we perhaps by August we could be slightly above 5,000, somewhere between 5,000 and 10 somewhere. And I think from other countries, you remember between 700 and 1,000. From there, you usually have a leapfrog of 10-fold, at least to 7,000. So I think one could imagine that, but that's again modeling. All models are wrong, more especially when trying to answer a question like this. It's even worse.
Okay, thank you very much for that. Willan Kalinda up in Ekwendeni, I wonder, would you like to come in? I know that you're traveling in Livingstonia today.
Hi, Stuart. I'm traveling and the road is bumpy, so I cannot be clear. I wish I come in later.
Okay, no, thanks for that.
Yeah.
I wonder if I might try and frame your question, actually, Willan, since you mentioned earlier, just in case you don't manage to come back. So, Dr. Phuka, the question was around messaging to rural areas, in that in Ekwendeni, Willan's shared with this group on several occasions that the messaging isn't getting through, that in some rural areas, the availability of soap for hand washing is a basic and fundamental challenge, and that other than a reduction in handshaking, there's really not much behavioural change going on.
Of course, I think the Ekwendeni area, to my knowledge, has been challenged by also lack of a good degree of perception. Actually, it's a question I asked colleagues at Inzuzu University, to say you have low-hanging fruits in terms of telling us stories, because along the lake in Katabe is perhaps the best example in our compliance, including today. The DHO Katabe is the one that has declared his status, which is really positive. When you move upland to Nzuzu, we had our response team stoned and so forth, but we have seen this in other cities. When you go to Rumpi and northern part of Nzimba there, we have had issues around disbelief, lack of acceptance. But in the same district of Rumpi, I also do know that some hard-to-reach areas actually said, no, don't bring any case. I think there was a case that they wanted to go home, sort of isolate at home. They said, no, don't bring this person. Don't bring this person here because you're going to infect us. So there's a clear variation in terms of the perception there. And then my take would be, again, when you teach, you need sort of and when you assess, you need to be very precise with that kind of community, because you could be getting a proportion of those that have not understood. But generally, I think the other thing is we had a competing consumer of information, that was politics. That now is gone, so things may change, because it seems the past few days already people are now focusing on the COVID. So I think it's the first challenge is resolved. There's a second challenge to look at. So maybe we'll have preferential attention to the consumption of health risk communication. But as in that slide, I showed that there has to be targeted theory-based approach that usually helps.
Sorry.
I can't hear you.
I'm sorry, yes. Then two questions on the chat. One from Mike Beresford at Zambezi Mission. Is a lockdown likely to be considered again in the future? And then from Kathy Radcliffe at EMS, a question about allowances. Apparently our partner Mulanje Mission Hospital, the district treatment centre, should be paying allowances that amount to around £5,000 per COVID patient, 8 staff for 7 days plus 2 weeks quarantine, plus loss of staff time during these 2 weeks of quarantine. Can this be changed, is the question.
Yeah, so the lockdown, as you can see, we perhaps should have, I mean, from the epidemiology and elsewhere, benefits of a lockdown really have been at the point you want to sort of seriously delay spread. Unfortunately, we had the reverse for ourselves. Instead, we had sort of an injection of a cluster coming into because of the returnees. Now, if you want to do a lockdown, I'm sure one cannot say it may not have benefits, but one needs careful review to say, what are we trying to achieve? What are we trying to lock down at this point versus the impact on the economy that is already happening naturally, and maybe we have lost already, we have a very weak economy, and so forth. So all this needs to come into play. Government, there's a new government. I think it will guide us in which direction it wants clear options with the cost-benefit analysis, cost-effective analysis, all that saying this is what we gain. But from our modelers, they will tell you that we already passed where we can have maximum benefit from a lockdown. So a serious review would have to happen. I think the next question was on the allowances. I think this is a really big challenge. At present, the government funds are second ranked from World Bank's ranking that has contributed just now a bit more than what the government has. So largely, we have to naturally have to come to terms with what we can spend on COVID as a response, because I think there's also a challenge that in the system, in some cases, taking care of patients, being in the lab meant that also people were working the normal hours, yet they could have asked for. So this needs to come sort of into very clear position what we mean. I do know that the strategy or the plan was that if you are the frontline worker, then you would have to be in the hospital for 2 weeks, and then all this, like you are part of those that are quarantined as well. So that might need special, but in terms of converting that to 5,000 per case, I'm not too sure what the figures are like. But I mean, I'm sure that maybe these are the correct figures. However, I think we need to ask ourselves questions on feasibility of whatever we are doing moving forward, including rerouting some of the resources, being extremely prudent on use of resources, the tests, and so that we can save some of the money for other activities. Thank you.
Thank you very much. And then there are, I think, 3 or 4 questions that, if you'd be willing to take together. In brief, I think the first asks whether the task force has thought of engaging academics more. Professor Tim Eden here in Edinburgh asks, have many children with COVID-19, have you had many children with COVID-19? Were any of them very ill or even died? I think we're going to come on with Professor Hugh Pennington just in a moment on to incidents in children as well, but very keen to hear your response to that, Dr. Phuka, as well. Then how well, Gift Louis WaterAid asks, are we managing self-quarantine of returnees as they get to communities? And how about ensuring compliance? Charles Howie at Malawi Fruits would like to ask if COVID-19 is affecting the movement of produce from farmers to urban centres. And finally, Heather Palmer, how are the rural areas going to cover COVID-19 testing? I think we'll probably come more onto COVID COVID-19 testing further in the programme. But any thoughts you'd like to give to these, please?
Yeah, so the movement of produce, I think, is not largely affected quickly. And then I think even our economy is largely tobacco based. That market is still there and functional. They have just taken precautionary measures. We are engaging as a committee, the university. So for that, I had to run back to my college. So the principal has been very helpful. We can chip in on that, on what we are trying to do in terms of research. But clearly we need support in terms of funding, because some of the questions we have need sometimes quick answers. So one would also want to say, would there be a different approach to how grants for research are? Because oftentimes this sort of writing a protocol and whatever, and then all these steps, by the time you want to answer that question, it's already gone. So I wish I was in a country that I would have a pool of money to be used to answer quick questions, which might actually be much more important in life-saving than maybe other also long-term questions, because we need responsiveness as we go along. Movement of produce, rural areas. I think what we did at the beginning of the response was to categorize different areas. Others, for example, Ilonge Blantyre, Nzimba, Mangosh were category 1 of potential cases. Then other category up until category 3. I think even most of the response should also begin to reason in that direction, so that other things could be much more functional elsewhere, whilst in high-risk environments, then you have stricter measures. We have seen this happen in other countries, including South Africa, so it might be a way to go. Minister of Health engaged 20th directive, putting requirements on Mulanje, okay, and they is not paying the cost. Yeah, I think there's a challenge in terms of resources. I think we have just managed to do about 40% of the resources. So clearly, as I indicated, we will have to learn how to be modest with our expenditure. If you see a country, a poor country like ours, a low resource country like ours, being top on resource mobilization, then you know that that country is by itself. And then when in the context of reduced revenue versus increased expenditure, one need to be much more realistic. At the start of events, we were all we thought this would come and go, but this is not a quick come and go event. I don't expect it to go out anywhere. If it's not out there in other places for 6 months, Malawi should brace itself for another at least 6 months before it goes out. So I would say we need indeed to be much more careful on that. But maybe my principal may want to chip in.
For me, it's just the academic that we are involved. We just want to say, like from the university, from the college, we are in the expert committees where we've sent people. We are in different forums, and even at the district levels where we are contributing on that. And I must say thank you also to some of our partners from Scotland that through their GCRIF funds, we were able to get funding that we are doing some research that is going to inform point of care and even behavioral type and also mental health aspect. So we are engaged. The good thing about it is that some of the things we cannot talk, but I can tell you that already even with the new government as a university, we are talking to see what can be done, bearing in mind that COVID is.
Thank you, Prof Mipando and Dr. Phuka. Just a couple more questions. We are running slightly behind, but really value your presence with us. There was a question around the involvement of mission hospitals that are present in rural areas and whether there are any plans for that. And then Shupo Kumwenda is asking about the involvement of community-based organizations to help spread messaging and whether there are plans for that.
So CHAM, the major The major contributor to healthcare service has representation at the Presidential Task Force, and clearly the member is a political member, was brought there on technical grounds. So my take is that if I may not be able to cover most of the questions here, can those come through Innocencia, those that are also in CHAM? Can you help facilitate the questions that are coming from colleagues? Then we can push them through Innocencia, or even some cues to what really should be done. We are also looking for much more solutions than and new ideas on how to do things. But in terms of resource, the response is meant to be really cross-cutting. Today, I also presented at the healthcare donor group, and I mentioned the private sector to be an important part. Beyond the private, within the healthcare sector, we need to sort of open up ourselves much more to response even within the private sector. That some of those can actually also support us. So the private sector phenomenon is even wider than the healthcare system. But CHAM is charity, so most of the support really need to be, as the government is enjoying it for its people, then it's supported by CHAM. That should be the spirit in which we should proceed. And largely, that has been the thinking. The trainings and other elements are in that context. And CHAM is in hard-to-reach areas. So I have been advocating and reminding people that our strength is community health, primary health care, and community health systems. CHAM cannot be left out in that response.
Thank you very much indeed, Dr. Phuka, Professor Mipando, for your time and very valuable contributions. Any other questions there in the chat? We will make sure that we send on to you so that there's an opportunity for these to be considered and any replies to be passed back to the group. But thank you very much indeed. You're entirely welcome to stay with us for this meeting as much as you have time to do so, but I'm conscious of demands on your time, but thank you both.
Thank you very much.
Thanks, Stuart.
Thank you. I'd like to turn now to Professor Hugh Pennington, who's Emeritus Professor of Bacteriology at the University of Aberdeen, for his observations and analysis on the relatively low instance of COVID-19 in young people. If Professor Pennington, I'm characterizing that fairly.
Yes, indeed. I hope you can hear me okay.
Yes, thank you.
Good. Yes, this is a very unusual virus in that the effects on people basically are so closely related to age that the older you get, the more likely you are to have the severe respiratory complications of infection and other organ problems like kidney failure, and we're now learning about neurological effects as well. And these really only start to kick in people over the age of about 40 or 50. There are people younger than that who've had a very hard time with this virus. And there is this rather rare syndrome, which has been called Kawasaki-like syndrome in young children, which is basically a problem that we've seen before, well, we haven't seen before, but other countries have had. It's been a particular issue in Japan, for example. It affects the heart and coronary artery vessels and so on. Usually the children recover, but this is a rare complication. And most children have a very mild illness. Many will have no symptoms at all. And as I've just said, the effect of this virus really only starts to kick in really in people over the age of about 60. And then the older you are, the more likely you are to have the very severe respiratory effects and so on. And there's a linear relationship between age and the bad effects of this virus, which is very unusual. With most viruses and many bacteria, we have serious effects in children, and then the age effect sort of disappears in the sense that people in their 20s, 30s, 40s, and 50s have rather little complications, and then they start to kick in again in the elderly. This is a very unusual virus in that there's a linear relationship between age and complications. Now there are unresolved issues like how common are infections in children? Are the infections themselves less common in children? And then how effective are children at spreading the infection either to their peers or to adults? And I think the consensus view at the moment is that if children are going to get infected, they'll probably get infected from adults rather than the other way around. And children themselves have a very easy time and are probably not very good spreaders of the virus, because this virus is, basically specializes in having super spreaders of people who either in a particular set of circumstances or because they are pushing out a very large amount of virus are associated with outbreaks. And we've seen this, it's been very well documented in countries like New Zealand, for example, where, gatherings where people get very active, singing and shouting is a very good way of getting the virus into the air inside. So we've had outbreaks in weddings and public houses, and there's been a very well-known outbreak in the United States in a choir practice inside, where half the choir members became infected. One of the choir members was symptomatic and so on. So we have a beginning to get a good understanding of the sort of situations where the virus really is very happy in the sense of getting about much more than it would do outside. And we know that outside is a poor place for virus transmission, that there's about a 20-fold less risk outside than there is inside. So I think those are the basic facts about transmission, and which of course have to be paid very, very serious attention to in reducing the amount of transmission and trying to stop transmission if one can. And then of course the effects of the virus themselves, as I said, there's a very strong age relationship, and other conditions like diabetes, high blood pressure, previous cardiac problems, and obesity are important risk factors on top of age in terms of basically causing people to have a very, very serious infection, which of course has a measurable mortality.
Thank you, Professor Pennington. Dr. Phuka spoke of the returns from South Africa creating a spike and then doubling from 300 to 600 new cases, and of crowded situations with social functions and funerals, and perhaps not much use of masks. Do you have any reflections listening to what Dr. Phuka said about transmission, whether super spreaders might be involved or what theories?
Yes, what Dr. Phuka said just mirrors the international experience with this virus, that many countries have had a hard time to begin with because of importation of the virus from places where the virus was already doing very well. And here we've got because of all countries in Africa, South Africa has had the hardest time with this virus, more cases and so on than other African countries. And, even in the UK, we had more than 1,000 importations of virus early on before we really knew we had a problem from countries where the virus was already spreading and causing many infections. Like, for example, in Italy, most of our importations didn't come from China, they came from other European countries where the virus had had a head start. So what Dr. Phuka said is absolutely typical for this virus, that the virus enters a country often with multiple invasions, as it were, and many of the people bringing the virus in perhaps wouldn't even realize they were infected, because we know that transmission by people without symptoms is really quite common. Many of the people will go on to develop symptoms, but people are infectious a day or two before they develop symptoms, and some people are infectious without having had any serious symptoms at all. So what Dr. Phuka said is absolutely typical of the international experience with this virus. And then there are the events like weddings, for example. Again, if we could go back to New Zealand, which has very good published records on this, they've had some of their biggest outbreak. In fact, their biggest outbreak was associated with a wedding and so on. So we know the sort of events that are dangerous in terms of spread of infection if the virus is about, and clearly control measures have to take that very seriously into account in the sense of trying to stop these super spreader events, which can lead to many cases, which then of course can spread out into the community, and one then goes on to this sort of exponential increase in case numbers.
Professor Paul Garside, I wonder if you'd like to put your question to Professor Pennington.
Yeah, I guess my question really is, there's pretty good evidence that the receptor for the virus, the angiotensin converting enzyme 2, the ACE2 receptor, is the expression of that on endothelium and epithelium is very low in childhood and increases with age. And actually that might be the link to age. And that might be the link for the differential effect, infection rate and effect in older people. And I think another layer of complexity on top of that is in somewhere like Malawi, and I noticed that Wilson Mandala is on the call, and as well as Mwapatsa, and perhaps they can also comment. There may be immunopotentiating or immunomodulating effects of concurrent infections. So infections that might enhance your immune response, which would be good in the early response to the virus, but bad in the later response, but also infections such as malaria that might reduce your immune response and inflammatory response that would be bad in the early part of the infection, but good in the later part. So I think context is critical here.
No, I would agree absolutely. The ACE2 receptor story is an evolving one, and there were issues about people with hypertension who are being treated with inhibitors of this have an increased incidence of infection, for example, or an increased incidence of complications. I think the evidence of that is not very good at all. But we do know about the receptor. That's obviously important. And in terms of other infections, there are anecdotal stories about BCG vaccination perhaps being sort of helpful in reducing the serious nature of the infection. I'm not absolutely certain how far that has gone, but there are these other issues of other infections which clearly will have an effect on individuals who become infected with COVID-19. And clearly much more research is needed to basically suss out these other effects. And the sooner we get the results of those kind of pieces of research, the sooner we'll be able to basically perhaps react to them in a positive sense in terms of reducing the effect of COVID-19 infections.
I don't know whether Stuart, that Mwapatsa and Wilson would like to comment, but I think the key point here is that actually contextualized research is what is key. Research being done in Malawi for the conditions that exist in Malawi, and I think that will not only be important during the pandemic, but also post-pandemic, when we start to see the consequences of the immune dysregulation that has taken place during the disease. We're seeing incidences of increases in autoimmunity, for example, and I think that will be very important as well. But Mwapatsa and Wilson are better placed to comment than me.
Yeah, yes, Paul, I would want to agree with you. Actually, just last week, I was seeing a summary of what is being seen in South Africa. The cases of HIV, AIDS, initially we thought there wouldn't be much difference, but now we are worried in terms of the context. So I know that with a group, we are trying to do a research to see what is the difference in terms of our Malawian context, because indeed our underlying causes, the environment, and even the prior exposure, might have some differences with what has been seen in Europe. So I would want to agree with you that we really need to contextualize what we are researching on back here on the continent because of what has been seen in other countries. The HIV story, if you compare what was seen in, I think, Korea and what is now being shown in Western Cape in South Africa, already there are some differences that you can see.
Thank you, Professor Mipando, very much. I wonder, would anybody else like to come in with a question for Professor Pennington or a comment?
I have one.
Please go ahead.
Let me just put my video on so you can see me. Yes, so I've seen no data that show that age is an independent risk factor for infection, number one. Of course, comorbidities and care homes aside, but as an independent risk factor. And secondly, if you look at the variability of the incidence in Europe and the fact that most countries in Europe had a lockdown, I see no correlation between the control of the disease and lockdown. So I wonder whether you'd like to comment on both those things.
Could you repeat the first one about age?
Yes, I've seen no data that show that age is an independent risk factor. So we know that one comorbidity and two comorbidities increases the risk substantially. We know that nosocomial infections, particularly in care homes, show a much increased risk of death. But as an independent risk factor, I've seen no data. I've looked quite extensively, but I wondered whether you could comment on that.
Well, yes. My own reading of the evidence is that age is very, very important in terms of a serious effect of the virus. That people under 40 compared to people over 80 have a differential mortality of 70-fold. The over 80s have a 70 times more increase in mortality rate compared to the under 40s. And we can compare it with other agents, but where we do see these very profound age effects, we can't explain them. It's not a simple issue about the immune system response or anything like that. It's just a straightforward fact, epidemiological fact, as it were, that age is a very, very important determinant of mortality in the infection. And
well, may I just comment on that? Because, of course, the older you are, the more likely you are to have comorbidities, and the older you are more likely to die. But my point is, as an independent risk factor, I've seen no data. So if you have, I wonder whether you could refer me to it.
No, I mean, as you say, the older you are, the more likely you are to have comorbidities, and separating those things out is obviously very, 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 very difficult. But my own view would be, looking at other pathogens that, as a microbiologist, I would accept that age is a very important determinant of mortality, and there's a very straightforward linear relationship between age, that the older you are, the more likely you are to die from the infection. As a straightforward issue, irrespective of the comorbidities, which obviously play a part as well.
So I think, rather than take up time debating that, can I ask you about the second one then, which is that if you look at Europe, which I'm more familiar with, there's a huge difference in the instance of the infection and also deaths, but every country has had some degree of lockdown. And so I've seen no relation between lockdown and the number of deaths. I wonder whether you could comment.
Yes, well, the example that's quoted is Sweden, which didn't have a very stringent lockdown compared to other countries. And, if you compare Sweden with Norway, for example, or with Denmark, where they had a stricter lockdown, the mortality rates are different. But on the other hand, I would agree with you that it's really very difficult to know exactly what components of the lockdown, even the really incomplete one in Sweden, has played a part in their experience. I would put quite a lot of weight on, for example, the number of importations at the beginning of a country's experience with this virus as determining, the subsequent events. In the UK, we had a lot of importations of virus, which we can now look at by doing, gene sequencing and finding out where the virus came from and so on. And I think that was that's been a bit of a surprise to some people anyway, that we have so many importations at the beginning, which seeded the virus right throughout the whole country, right from Shetland to Cornwall, for example, and what impact the lockdown has had on the subsequent events is really quite difficult to say. I think the Oxford people think that the social distancing, the 2-meter rule, or that kind of social distancing has been far more important than the other aspects. But we know from outbreaks that public events, like singing in pubs, are good ways of getting these super spreader events. So closing those down may well have prevented outbreaks happening that otherwise would have happened in those social events. But flushing all that out in terms of the actual numbers is going to take a long time. We'll probably never get a clear answer about it.
Thank you.
So one more follow-up, and then I won't take up any more of your time. A more dramatic example is Italy and Japan. So Italy has population of roughly 60 million and incidence of 40,000 deaths. Japan has twice the population and only about 1,000.
Yes, I mean, one hesitates to talk about the effectiveness of their intensive care systems, but that must be taken into account, that some countries have been better at treating the patients who got into very severe respiratory problems than others. But exactly what role that has played in these differential mortalities, I don't know.
Thank you.
Thank you very much. Professor Paul Garside has just put on chat a link to CDC information on risk factors, including age. So hopefully that will be of interest to all. Professor Pennington, we seem to be getting more advice in the UK about the importance of wearing basic cloth masks in everyday business in shops and enclosed places. Is that your view, that it's essential that this happens?
Well, I think the evidence on face coverings and masks is that face coverings are not as effective as masks, and particularly masks with several layers, in terms of preventing an infected person infecting others, because that is the main utility of masks. I think it's rather than offering protection to the wearer, it's reducing the likelihood of an infected person passing the virus on to people in close proximity. And clearly, the more sophisticated the mask, sophisticated in the sense of the tighter fitting, and the more training the person has had in wearing the mask, I think there is some quite good evidence that that's an important factor. So, what degree of protection to the community at large is presented by wearing a face covering? I'm not absolutely certain, because clearly it will depend on the material of which the face covering is made. It depends on the person who is infected. What are they doing? Are they talking? Are they shouting? Or whatever it is. In terms of emitting virus, it's a very difficult area, I think, to establish any, get any really hard evidence on, except that it's common sense, in a sense, without going to the physics of movements and so on, to expect that there will be a reduction in the amount of virus being emitted by someone wearing a face covering. But on the other hand, I think wearing a face covering is not going to be very protective to the wearer against virus being emitted by somebody close by and so on. And so it is a complicated area. And of course, one then has to bear in mind how the masks or how the face coverings are being worn. Where, if people are touching them, what are they then doing with their hands that have touched perhaps virus on the surface of the face covering or the mask? And there's quite good evidence that the home of the virus, essentially in the upper respiratory tract, is essentially the nose. And one sees quite a lot of people wearing a mask which is not really tight fitting around the nose, or even not covering the nose at all. So there are all sorts of issues about how the masks and how the face coverings are worn, which one has to take in mind, bear in mind when thinking about the utility of them. There is obviously a kind of perception, if people are wearing these masks, that they're taking the issue seriously, which is quite different from the degree of protection or otherwise that they're giving to those particular individuals.
Well, thank you very much indeed, Professor Pennington, for joining us. I know that there are many calls on your time, so we do appreciate that. Please feel very welcome to stay with us for as much of the meeting as you'd like to have time for today. But for now, thank you.
Thank you.
A question from Mick James, which perhaps would be for you, Professor Mipando. In the context of Malawi, given the number of deaths caused by COVID-19, is the focus on the virus starting to detrimentally shift the health agenda away from the main cause of local mortality?
Yes, in a way, because I know that I had my head of department from Ops and Gynae had a similar meeting where they were discussing the issue where people, even the health-seeking behaviors are changing. People are not going into the hospitals. We are seeing reduced numbers. And even in terms of the meager resources and even the human resource, we have spread it to COVID. So yes, it is having an impact. I know the government tried to recruit some members, but that might not be enough. More so now that we are seeing quite an increased number of healthcare workers being affected by the disease. So it has an impact that we are seeing. And I think as the numbers increase, this will even be higher than now.
Okay, thank you for that. I'm very pleased that we are joined by the Deputy Director for DFID Malawi, Anthea Kerr, who is going to give us an update on work that DFID Malawi has been involved with in response to COVID-19. Anthea, over to you. You're very welcome.
Wonderful, thank you very much. I hope you can hear me. Could I just do a little sound check?
Yes, thank you, loud and clear.
That's great. First of all, I have some apologies to make. Firstly, I wanted to apologise on behalf of our senior health advisors. They were hoping to join, but some of you may know Kassa, our health advisor, is currently drawn down to Ethiopia, and there are internet connectivity issues in Ethiopia today. I also want to apologise for not having a suit on. Essentially, I was drawn down back to the UK just with one suitcase, and the one thing I forgot to pack was my suit. So apologies for a slightly scruffy jumper. Thank you very much for allowing us to come and sort of join and let you know of what we've been up to. I'm very happy to take some questions at the end, but I just wanted to sort of outline what our initial analysis was and then what we have done so far. So just to look at sort of the context of COVID-19 in Malawi, you know, our analysis is that it does pose a major health risk. There are models, there's a lot of modelling. The early ones were forecasting up to potentially 50,000 deaths in Malawi. And models also initially suggested that many of the 17.5 million Malawians could indeed become infected, with a great deal needing hospitalisation. I have been listening to the discussion, and you know, even though the discussion about sort of age, even though the population is young, there are sort of some severe underlying health risks that all of you will be more than aware of, with 38% of children stunted, HIV/AIDS prevalence at around 9.6%, and about 10 million Malawians, and I was trying to check the most updated data, don't have basic sanitation, and I think we heard very strongly early on about you know, the real need for hand washing. And I think especially in urban areas, we have a lot of people living in very difficult situations in many of the urban areas as well, and that's probably where transmission is also a major concern. So we looked at the health system as well. You know, there were only 37 ventilators in the country. I think critical care capability is very, very limited. And I think there's a risk, and we heard that again earlier on, of the risk of disruption and broken sort of supply chains, and human resource shortages, and sort of another worry for the health system is also that COVID could have an impact on other diseases, with, I think, one of the models predicting that there could be up to 50% increase in HIV, TB and malaria, and other mortality. And I think, you know, it's projected initially, and this is going back to sort of March and the initial analysis in May, that £62 million was needed, just as a starting place. But ultimately there's going to need to be an awful lot more as the scale, the impact and the cost of the pandemic in Malawi becomes clearer. And also that knock on to the other essential services that I mentioned. I think the government had also identified WASH as vital, because that was just for health, that estimation. So I think, you know, many of you will be more aware than I am, but, you know, 70% of the population currently live under the poverty line, and a lot of those people require sort of constant emergency support every year, with seasonal poverty and then obviously compounded with climate shocks. I think the most proximate humanitarian risk of COVID-19 is around the loss of livelihoods and food insecurity, especially but not limited to urban areas, where people have very few coping mechanisms. I think that you know, at the moment, you know, employment protection is not really in existence, and it covers what there is, covers very few people. And, you know, I heard the discussion and some of the questions around whether or not there's likely to be a lockdown or not. There is a balancing act to be had here, given that, you know, movement constraints could see informal workers lose their entire earning power overnight. And especially when they face a lot of sort of fixed financial obligations. So there are designs for a rapid sort of new social protection mechanism for that caseload, I believe, with the World Bank. I think there is still, I mean, we can't ignore obviously rural areas. There is a sort of small social protection system in place, and you know, there are resilience-based interventions. Most of these are fully financed by development partners. One positive is that there has been a relatively good maize harvest, and it should provide sort of short-term rural food security. But we do predict that there could potentially be a challenging lean season, which is the November to April window. And that could actually start earlier than usual, affecting potentially greater numbers of people and with greater depth of need. I won't talk so much about the wider economy, but IMF has lowered, I think, its growth forecast. I'm afraid I don't have the most up-to-date figure, but they are predicting a slow recovery. And I think the fiscal space to manage sort of a deterioration in the economy alongside a health crisis is going to be particularly difficult in Malawi. You know, at the moment, the fiscal deficit is running from 4.9% of GDP pre-COVID to 9.3% already. So the World Bank has released $30 million worth of general budget support, and I understand that the African Development Bank is considering emergency support as well, if not already. But I think one of the critical things is going to be maintaining trade flows and trying to protect revenue and growth generating export sectors to make sure that they don't collapse. So that's sort of some of our analysis that goes back to May of what our initial analysis was. In terms of what DFID and the UK has been doing, we moved really quite quickly. Right back in March, we had already started putting together our response, and I just was going to go through the areas that has covered. So one of the first areas of focus was the national laboratory capacity, to strengthen that, to be able to undertake the lab confirmation and diagnosis of COVID-19 in the country. We funded the training of the lab technicians, and then also managed to facilitate the transport and accommodation of the technicians who were able to calibrate a lot of the machine, or the main machines, and then also making links with the South Africa labs and the CDC lab in Zambia to get the necessary lab packaging equipment for the transport of samples while we were waiting for Malawi to be able to test itself. We've done a lot on strengthening point of entry capacities for air and land border, the crossing screening and isolations. So that's everything from funding the provision of health declaration forms, hand washing stations, infrared thermometers, and PPE for Port Health Authority officials at land and air border crossings. And then actually helping do the screening, and engaging the Airport Development Limited, the ADL, and the Civil Aviation to advocate for provisions of houses for health port officials during duty hours. And then actually funding a lot of the resources needed for the follow-up for passengers arriving. And that initially was all of those that were arriving from mainland China at the time where we started, but was then broadened out. And then also obviously the contact tracing. And a lot of training, of course, for immigration, MRA, conveyors and health staff has taken place. The third area that we covered was sort of making sure that we could actually procure and distribute clinical equipment, PPE, medication, lab, actual equipment into the health units and the district health offices. And then just making sure that there was funds available to monitor the use of all of that equipment as well. And to some degree, we've been able to help with the procurement of treatment in some areas, although obviously there isn't a full treatment available. But we were at the time of design looking at sort of some of the Ebola treatment, and then also some of the cholera treatment, making sure that we could harness what we've already got in place. So that's mainly around WASH. And then the fourth area was actually funding the setting up of standard emergency treatment units, and these focused on Lilongwe, Blantyre, Mazuzu and Machinji ETUs, and that was establishing them with WASH, like a permanent water supply, making sure that there were toilets and bathrooms in place, power, fencing, and that infection prevention is in place, getting solar power for the ETUs, water trucking until such a time as water was actually on tap, and then just making sure that they were fully operationalized with the department, you know, making sure that the staff were deployed there as well, covering things like lunch allowances and compensation for those health workers. And then we've also made sure that any patients who are discharged from ETUs have a package with all the messaging leaflets, masks, bucket, soap and chlorine, so that we can reinforce control measures at home. And then there's regular follow-up of the care afterwards. And then the fifth area, it sort of cuts through, and you will have heard me mention it, but we developed and updated training packages for district national rapid response teams and for the health workers. And that's all obviously in line with the WHO guidance. And then actually being able to provide bespoke, we funded sort of some bespoke case management training for 200 health workers across targeted districts. And then making sure that there was enough funds so that core case management teams and RTs were able to sort of share updates. And then there was a little bit of work with private institutions as well, making sure that they were up to speed on how to do the surveillance, case definition, screening, and then referral of suspected cases to the ETUs. So that was the fifth area. The area that we came out the quickest on actually was around the awareness campaigns. So I think that I have shared them, and I'm not sure if they went on the website, but I shared all the original ones in case anybody wanted to actually just print them off themselves before, you know, while waiting for UNICEF to provide them to anyone in Malawi. But basically there was just a lot of work to get the messages out there, and then trying currently to link up with opinion leaders in the community in order to sort of demystify quite a lot of rumours, fake news and misconceptions. There was quite a lot at the beginning, there's perhaps less so now, but still something that we continue to push on, which is the messaging. So we haven't, that's sort of our direct COVID response, but something else that we thought was incredibly important to do was to actually pivot, what we call pivoting. So taking our original programs and then adapting them to the COVID response. So we've done that across our livelihoods programs and all of our economic development programs. And then lastly, we've also done it within our violence against women and girls programs, because we were particularly worried that had a lockdown occurred, that actually there could be increases in violence against women and girls. So all of that is ongoing at the moment, as all those programs continue. So that's just a very brief summary. I'm sort of wriggling because I can see people pinging on my work email to tell me I've got 6 minutes to get to the next meeting, but I am very happy just to delay a little and take any questions.
Thanks so much, Anthea. I know that in a previous meeting that there was one of the participants spoke of how great it was that DFID was so fleet of foot in pivoting, enabling them to crack on with a project within just 24 hours. A question from Dr. Tracy Morris, who's traveling in Malawi with a bad connection at the moment. Given the importance of WASH in Malawi, is there a possibility that DFID Malawi would consider reopening funding for this since it's been previously pooled?
There is, I mean, within the UNICEF, all that I articulated on the health side is with UNICEF. So specifically on our COVID response, that's what we're doing, and there is WASH integrated into that. In terms of standalone WASH programs, and even looking into the future, I think at the moment that's unlikely.
Thank you. From Mick James, what are DFID's thoughts about the need to support education, and what, if anything, are you planning to do?
Yeah, so I could probably come back a little bit on the education side, but our education advisor has remained in country. She has just taken up the chair of the donor group with the Ministry of Education, and has been working really closely with looking at the school openings, looking at what protocols need to be put in place. Obviously, everyone on this call is aware that there has recently been a presidential election, so just waiting at the moment on the nominations of new ministers, etc., to be able to take that back up again. But there's quite a lot of behind the scenes work being done with the ministry itself to start looking at sort of what the opening up would look like, and then what sort of protocols need to be put in place. Education remains a priority for the UK and Malawi.
Thank you. And Kathy at EMS saying you've allowed us to pivot elements of our UK aid match grant in Malawi. Thank you.
Oh, I'd love to tell you it was all on me, but I am proud of what our institution has done nonetheless.
Well, thank you very much for joining us.
Well.
Conscious that we've probably only got 4 or 5 minutes now.
Listen, thank you very much for the opportunity. Hey.
A pleasure. Thank you. So we'll move on in our agenda now, if we may, and I would suggest that we move to PPE distribution, local production. And I'd like to invite Callum Wilson. Callum, if you're still with us, who's a PhD student at the University of Glasgow. I'm sorry, University of Strathclyde.
Yes, hello. Thank you, Stuart.
Hi, Callum, go ahead.
Okay, so we at the University of Strathclyde started a group of students with various engineering backgrounds and other biomedical backgrounds to try and create a group that could support the COVID response. And so given the university's existing links with Malawi, we decided that Malawi would be a good target country to, if we were aiming at kind of developing countries, and in Africa, we decided Malawi would be a good place to start. So I was put in touch with the Scotland-Malawi partnership by Pam Wilson, who's also on this call, I believe. And what we really wanted to do is try and establish local links to partly facilitate knowledge exchange, so that we're not just working in our own isolated bubble here in Scotland. We could actually create partnerships and links with universities in Malawi who we know are already doing excellent work on this themselves. The initial direction of our project was pursuing manufacturing constant positive airway pressure devices, CPAP devices. And this is what we've been going along with so far. We've secured some funding to start building prototypes and do other procurement of materials and things like that. However, we're also very prepared to, again, that word pivot at some point and change the direction we're going in to develop things that are best suited to the needs in Malawi. So thank you very much for inviting me along to this. It's been a pleasure to listen to what's already going on and get a detailed update of the situation. I hope that over the next month or so, we'll be able to keep in contact with relevant people and start establishing these links so that we can best use our expertise to help.
Thank you, Callum. And if anybody would like to get in touch with Callum about that or anything related, then please just put an email into the chat function or send an email to us at the Scotland-Malawi Partnership. Any of the staff will pass that along to him. Callum, Professor Paul Garside mentioned the possibility of connecting with Dr. Wilson Mandala at MaSP, Malawi University of Science and Technology, who's been on these meetings with us as well. So we'll make that introduction as well.
Yep, great, thank you.
Thank you. Amy Blake, I wonder if you'd like to come in, CEO of Classrooms from Malawi, to speak about some of the work in PPE that you've been doing.
Hi, can you hear me okay?
Yes, thank you.
Oh, that's good. I'm on my mobile. Yeah, so thank you. I'll just be quick because I know that you're running a little bit over, but I just wanted to let you know. Can you hear me still?
Yes, thanks, Amy.
Sorry, it's really dodgy here. So we have launched a campaign about 10 days ago now to raise some money to get some hand washing stations into the partner schools that we've previously worked with in Malawi. So there's 31 schools across 9 districts. So we were actually completely blown away. So within a week, we've raised all of the funds required to get 300 hand washing stations into those schools. So we're going to be starting the distribution next week. We've talked a lot on this call about the importance of hand washing, and although the schools are closed, the hand washing stations are going to go to the mothers groups of each community, and they're going to do an education program around the importance of hygiene. So really my input here is an offer, because we're doing the distribution as of next Monday, going to these 9 districts, and that's across the whole of Malawi. So if there is something that we can do to support any of the other member organisations whilst we're on this distribution, please email me. So I'll put my email address into the chat. It's amy.blake@classroomsformalawi.org. But we're going to be in the districts, in the communities, talking about the importance of hygiene and hand washing. So let me know, please, if there's something that we can do to support any of the member organisations. Is that okay?
That's great, Amy. Thank you. Yes. Lovely. Right. Moving to a conclusion, I think, just conscious of time. I wonder if there's anything anybody else would like to raise that they feel they've not had an opportunity to do so far. Conscious that we've quite a few agenda items that we've skipped over, but there was quite a lot of content in the opening and the beginning there. So I hope that we've at least covered some of that ground, but we'll certainly seek to pick things up in the next one. So David, I wonder if we might turn to you for a summing up of actions arising, please.
Thanks very much, Stuart. I think fantastic job keeping us the time and covering so much in 90 minutes. Let me take just a couple of minutes, if I may, to pull out some of the highlights for me. I know people understandably had to come and go during the call, so it's sometimes useful to highlight these. We started with my counterpart, Vera Kamtukule, in Malawi, talking about the political context. And again, we join MaSP, and I suspect all of our members in congratulating the institutions in Malawi for the successful conduct of last Tuesday's election. We were extremely grateful to have Dr. John Phuka and Professor Mipando with us to brief the meeting. Really interested with Dr. Phuka's slides that we'll share straight after the meeting, showing the trajectory that the virus has had in Malawi. The first couple of months largely flat, and then with 2 spikes, one 25th to the 31st of May, where it's tripled in 5 days, and then in the second half of June. I think we recognize the success that Malawi has had with the closure of schools, the decreased attendance of churches, the enhanced hand washing as people enter buildings, but we recognize those challenges that have been identified by Dr. Phuka around crowded rallies, around face masks, and about hygiene once people are in buildings. I think we really heard Dr. Phuka when he was talking about the need for maybe more funding to engage academia, but also speed of turning around that funding for Malawi to be able to ask the pertinent questions and quickly get answers through its academic cooperation. And delighted to hear that some of the Scottish and UK funding was helpful in that regard. I think one of the clear messages we heard was the importance of having clarity and consistency in that public messaging, that simplicity of just washing your hands, and how important that Dr. Phuka thought that was going forwards. Absolutely delighted to have Professor Hugh Pennington with us this afternoon. Thank you for his time. I think really useful to have that point emphasized about the relatively low prevalence in young people, given the demographic differences between Scotland and Malawi. And his emphasis around those super spreading events, those large gatherings involving singing and shouting. I thought Paul Garside's points about receptors was very, very important. We'll make sure that that's highlighted in the notes. But as a number of people said, the real importance as we look to understand COVID, that we must contextualize, we must understand the Malawian context, its environment, its demography, its geography, its prior exposure to HIV and malaria. thank you very much, Anthea, Kerr, for joining us from DFID Malawi. Just briefly summarising the 6 main things DFID have been doing: the national laboratory, building their capacity to diagnose, strengthening at the point of entry, reserves distributing clinical equipment, the standard emergency treatment units, the awareness campaign, and supporting DFID-funded organisations to pivot. Thank you again for Amy Blake and Callum Wilson for their updates. In closing, let me just highlight some of the things going forwards that we, the Scotland-Malawi Partnership, will be doing. As I say, in the next couple of days, we'll release the video from today, the presentations and full notes. We have an article in the Scotsman today. Please do have a look at that, talking about cooperation between Scotland and Malawi on COVID. If you're not already a member of the Slack group, you can do that on your phone or on a desktop PC. They have groups that has groups on faith links, PPE, youth advocacy, appeals, and group visits. It's a great way between these now monthly Zoom meetings to keep in contact with the sort of 120 or so stakeholders that regularly take part in these calls. Our weekly bulletin to members now has a permanent section giving updates on the numbers for COVID in Malawi and Scotland. If you haven't already, do consider writing a perspectives piece for us, either you in Scotland or your partners in Malawi, how you're experiencing COVID-19. We're really keen to continue to share those, I guess, sort of snapshots of how people are experiencing it, whether it is through blogs, through articles, or through videos. We continue to fundraise, raise awareness of the 15 fundraising appeals for COVID-19 in Malawi. Delighted to hear from Amy Classrooms in Malawi that that's been very successful. If we're raising awareness of one of your funds, please do keep us updated about how you're getting on, and we will continue to publicise those. Our website, our web hub, COVID web hub, so scotlandmalawipartnership.org/COVID-19 is the main area that we continue to update. Please do go there for all of the resources. Andrea was making references to various resources that we're sharing. They're all there. Please do continue to use and follow the principles of good practice that we as a group have agreed. Quite a number of NGOs have signed up to those principles and a number of funders as well. DFID Malawi, through various conversations, many of those principles are really being adopted by DFID Malawi. The Kerr Foundation has given a formal statement of support, and I was delighted in speaking to the Scottish Government yesterday to hear many of those principles carrying through in the Scottish Government's response as well. I propose the next meeting of this group happens in around a month's time, so towards the end of July. If you would like one before then, or if you would like the Scotland-Malawi Partnership to do anything else between now and then, please do let us know. We are your network and we exist to support your work. I will write very shortly to incoming President Lazarus Chakwera as our honorary patron on an ex officio basis, sending a message of support from the people of Scotland to Malawi through the COVID-19 crisis, and re-emphasising the support that the people of Scotland and our 1,200 members are keen to offer. Let me close by just very briefly thanking everyone for taking part, thanking all of our fantastic speakers who have given up much of the afternoon to share their expertise and their insight. And thank you finally, of course, Stuart, my colleague, for chairing these meetings so coolly and so effectively. I wonder at some point, Stuart, before we close, if we could do another sort of turning on the videos, if everyone could turn on the videos at the risk of being indulgent. It's nice to be able to get a photo and share it on social media to see all of the people that we're speaking to. I don't know, Stuart, if now's the time to do that, if that's okay.
Great, sure. I think we just then have a survey slide as well, David, to invite people to give us feedback before everybody heads off. So if you'd kindly turn your videos on, as I see some of you are, and give us a wave, then we'll do a screen grab with a loving close-up, which we can use. There's Jeremy giving us a wave. Thank you.
Good stuff. It's always strange having talked to the ether, to black screens mostly for most of the time. It's wonderful to see everyone's faces and that everyone's smiling. We can compare notes of who's got the best bookcases or bedrooms in the background. But lovely to see you all. Stuart, back to you.
Great. Thanks very much for the summary, David. Craig will just in a second share the survey slide, which enables you to give us instant feedback which is useful to us, and we do take account of. As you know, in the sign-in process, there's an opportunity to volunteer questions, agenda items, and updates. We recognise that we don't always get to all of these in the meetings, and apologies for that, but hopefully we do get to the majority, and we'll try to scoop up others that we've missed in future meetings. A recording of the full Zoom event goes online, available via our website, and then a summary, as ever, will be sent round of David's key points arising from the meeting. But for now, again, thank you very much for your time and your participation, which we don't take for granted. We'll be in touch, and take care. Thank you. Bye-bye.